Everyone, and you are all welcome to this session 2 of the WHO Track Digital Learning Series, which are really aimed at providing technical resources for AHD capacity and knowledge, and hopefully in the long run, reducing mortality and the incidence of some of the infections associated with advanced HIV disease. So the session 2 topic is diagnosing, preventing, and managing cryptococcal disease. And I am David Mayer, an infectious disease physician who will be chairing this webinar. So we're just going to start with a few housekeeping issues that you need to be aware of. One, this webinar will have interpretation in French, Portuguese, and Russian. And you can essentially click the interpretation button on your screen and choose the language that you'd like to hear. And once you've done that, you should then just be able to click mute original audio, and you should have the interpretation with you. And there's 2 specific areas that you can type into. One is the chat group. That's really supposed to be for troubleshooting any problems that you might have with Zoom. Use the chat function, but there's also the Q&A feature for questions that are really focused on the content of the presentation for this webinar. And it's also important for us to remember that there will be a live transcription. There's the capacity to have live transcription. So if you'd like to have that, click on show captions at the bottom of that running part of the screen, and the caption will appear on the screen. And to close it, you just click hide captions, and you should be able to close that. And then finally, this session is being recorded, and the assumption is that your attendance is consent to be recorded. And we will also have a certificate of attendance and a CME provided through the University of New Mexico. But in order to receive that, you'll have to follow up via email at the end of the session, and the link will only be open for 48 hours. So that's a bit of a tight timeline there. And again, just to highlight that Project ECHO collects the registration, participation, Q&A, chat comments, and poll responses for some ECHO programs. So we will not be including any personal identifying data with the project funder, but it might be used for different things, including quality assurance, surveys, communications, evaluation, and research. So an example is just highlighted in the map that is bottom left of your screen, and as well as a pie chart on the right bottom part of your screen. Okay, and so just to start us off, I will introduce the first presenter. So we have a host of exciting presentations during this webinar, and we look forward to listening to excellent talks, but also, I think more importantly, answering some questions that have been either prepared by the presenters or questions that have been asked by the people that have registered. And at the end of this, we'll also have a panel discussion that should hopefully generate a lot of conversation. So David Lawrence is going to be our first presenter, and David is an HIV and sexual health physician and a clinical researcher at the London School of Hygiene and Tropical Medicine, and is also affiliated with the Botswana-Harvard Partnership. He was the lead doctor for the Ambition CM trial that recently completed, and his current work focuses on implementing the trial findings and translating the progress made with cryptococcal meningitis to other HIV-associated fungal infections. So David, welcome, and please take it away.
Brilliant. Thanks very much, David, for the kind introduction. And thanks very much for the invite here to come and talk today, along with my colleagues based in Botswana at the Botswana-Harvard Partnership. So as you said, my name's David Lawrence. I'm a HIV doctor and a researcher. I work for the London School of Hygiene and Tropical Medicine. And I was in Botswana for around 4 years as the international lead doctor for the Ambition trial, which has led to the revision of the WHO treatment guidelines for cryptococcal meningitis. And so today I'm going to try and give you a whistle-stop tour of everything and anything about cryptococcal meningitis, particularly with a clinical perspective around the management of these individuals. And there's quite a lot of information here, but these resources are going to be shared with you probably in the next day or two. And you'll see that I have highlighted a large quantity of additional resources and further information for you. So you'll be able to access this information very soon. So why are we talking about this? Why are we having these track webinars? Well, of course, I think I'm preaching to the converted when I talk about the fact that advanced HIV disease is still a very prominent public health issue. And actually, we're still seeing a very persistent proportion of individuals who are diagnosed with advanced HIV disease, so a CD4 count less than 200 upon diagnosis of HIV, but that also a large proportion of individuals living with HIV are tending to sometimes fall out of care, have their treatment interrupted, and then present back to care with advanced HIV disease. And these are data from South Africa and Botswana demonstrating that roughly a quarter of individuals, 25 to 30% of individuals newly diagnosed with HIV are diagnosed with CD4 counts less than 200. And when you think about how trends have changed over time, although we are having, as I said, fewer new diagnoses of HIV in many parts of the world, we are still seeing a relatively persistent burden of advanced HIV disease, with cryptococcal meningitis being one of the manifestations of that. So these are data on the left-hand side showing the number of cases of cryptococcal meningitis diagnosed in South Africa over a 10-year period. And you'll see that the number of cases hasn't really gone down in spite widened access to antiretroviral therapy. And these are our data here on the right from Botswana, which is showing that amongst all CD4 counts below 100 in Botswana, it was originally that the majority of those were among people newly diagnosed with HIV. But what we're seeing now is that actually the majority of individuals with advanced HIV disease are individuals who know their status and have at some point been linked into care or have at least been on ART for a period. So that means that the kind of the patient group that we're dealing with are slightly different, and we are seeing more ART experienced individuals, which is really important when it comes to considerations of ART management in cryptococcal meningitis. So there have been updated global burden estimates published recently, but this is a very nice global map just highlighting the annual incidence of cryptococcal infection, which is seen most commonly in high HIV prevalence areas. So what is Cryptococcus and cryptococcal meningitis? Well, Cryptococcus is an encapsulated yeast. It's a fungal infection, and it's a ubiquitous yeast, which means that essentially this organism is present almost everywhere in the world. It's found in soil. It can be found in bird droppings. There is almost near universal exposure to this pathogen. The majority of people who are exposed to it will inhale it. It's spores that move through the air and then are breathed in through the lungs. And for the majority of people, that does not have any lasting impact, and they'll clear that infection. A small proportion of individuals will go on to develop a respiratory infection, but actually what happens in the majority of individuals is basically not a lot, and there's a period of latency, which means that the infection, the organism may remain in the body, but not cause any active illness. But in the presence of immune compromised, a weakened immune system in the context of advanced HIV disease, but also as well in individuals who are immunosuppressed for other reasons, there can be a reactivation of that infection. And that basically means that then sometimes the infection will spread from the lungs into the blood and around the body. And when the infection is in the blood, that's a state that we call cryptococcal antigenemia. That means that the antigen, the cryptococcus, is in the blood, and then that's followed by the spreading of the cryptococcus to other parts of the body. And with the most serious manifestations of this being the brain, when individuals develop cryptococcal meningitis. Now, one thing that has really revolutionized the management of cryptococcal meningitis in recent years has been the development of highly sensitive and highly specific rapid diagnostic tests, with the most widely used, the IMI CRAG cryptococcal antigen lateral flow assay. And you can see here it's a very simple test. You just require a very small volume of blood or CSF, and it can be whole blood, serum, plasma, and a small quantity of blood, a drop, with a lateral flow assay, 10 minutes, yes or no. And this has really revolutionized the whole landscape of cryptococcal infection. It is what has led us to be able to develop and implement CRAG screening programs, and also to be very certain of our diagnosis when an individual does have cryptococcal meningitis. So cryptococcal antigen screening is a really essential public health program, particularly in areas with a high incidence, a high prevalence of HIV. And different countries now have adopted CRAG screening policies, with the majority advocating that all individuals with a CD4 count less than 100 should have a reflex cryptococcal antigen test. So that means that if a blood test goes to the lab for a CD4 test and the result comes back as less than 100, then the lab should automatically test that sample with a cryptococcal antigen and then feed that back to the clinician. And we know that globally, amongst individuals with a CD4 count less than 100, the antigenemia prevalence is around 6%. And there's still a bit of debate about the implementation of this same policy for individuals with a CD4 count below 100, between 100 and 200. But we know that the global prevalence is kind of around 1.5% to 2% in that population. And of course, it also goes without saying that an individual with advanced disease or symptoms of advanced disease and neurological symptoms should also be CRAG screened. So this is screening of blood. And then what we're starting to understand more and more are the different phases and the continuum of cryptococcal infection. So you have individuals with advanced HIV disease who have a negative cryptococcal antigen in their blood. They don't have active cryptococcal disease. Then there are individuals who have a positive cryptococcal antigen in their blood, but don't have meningitis and don't have any symptoms. And those individuals have asymptomatic cryptococcal antigenemia. Now, there's also then obviously this transition, because an individual goes from having the antigen in their blood to having it in their brain and developing meningitis. And that happens over a period of time. We're not entirely sure how quickly, but we're talking kind of weeks rather than months. But there's a period where some individuals will have developed meningitis and developed cryptococcus within their CNS, within their central nervous system, but it might be so early in the course of the infection that they haven't yet developed the common signs and symptoms of meningitis. And these are individuals who may look very well, may feel very well, but actually still need to be treated for meningitis. And the message here is that really it's extremely important that everybody who has a positive cryptococcal antigen in their blood has a lumbar puncture to try and check if there's any cryptococcus in the CSF, because some people won't have any symptoms. And this is a phenomenon we describe as subclinical cryptococcal meningitis. And then, of course, right at the other end of the spectrum is the overt cryptococcal meningitis, when individuals have quite clear symptoms. So what are those symptoms? Because an individual who is presenting with a positive cryptococcal antigen does need to be assessed to see if they do have meningitis. So what are the symptoms? Well, of course, headache is the most common symptom that occurs in most individuals with cryptococcal meningitis. In more extreme cases, individuals present with confusion or loss of consciousness, behavior change. And we know from clinical trials that it's about a third, maybe 40% of individuals who are presenting at the point where they're confused. There's also the symptoms and the effects of raised intracranial pressure, where Cryptococcus causes a blockage in the flow of the fluid around the brain, the cerebrospinal fluid, and that pressure increases. That's what's causing often the headache. But as the pressure increases within the brain, that can also lead to things like seizures, nausea, vomiting, double vision, visual loss, hearing loss. So there's a large number of neurological manifestations of cryptococcal meningitis, as well as those manifestations outside of the nervous system, such as skin changes, generalized weakness, cough, chills, fevers, and weight loss. The clinical examination, the patient in front of you is likely to be holding their head in a significant amount of pain. They're going to look immunosuppressed, they may be confused, and they may be having or recently having had seizures. And I'm sure that all of the clinicians on the call here know very well how to examine someone for symptoms of meningism. There are also some specific neurological findings that are very common, with the sixth cranial nerve palsy being one of the most common manifestations of raised intracranial pressure. And it's what's often described as a false localizing sign. It's a focal neurological deficit, but it's not necessarily related to a space-occupying lesion. It's actually related to a kink or a bending in the sixth cranial nerve, which makes it difficult for someone, or impossible for someone to, with the affected side, look out, abduct their eye in that direction. And that's a sixth nerve or a lateral rectus palsy. And the reason for that is that this nerve actually uniquely passes into the eye through a very narrow os here, the temporal os, which when you have increased pressure around the brain is very easy to get kinked. So if an individual has just a sixth nerve palsy, that's an indication that they have raised intracranial pressure, far more likely than they have a space occupying lesion. And if you're very good and you have an ophthalmoscope, that raised intracranial pressure, because it's putting pressure at the back of the eye, can push all of the pressure around the optic disc and cause a bulging optic disc, which is evident on ophthalmoscopy. Skin manifestations are also extremely common. There are lots of different manifestations. However, the most common by 99% in my experience are cryptococcomas here on the right-hand side under B. And these are umbilicated lesions across the body. They're papules, and they're very easily could also look like molluscum contagiosum. There are other manifestations as well. However, these are far less common. So ultimately, the diagnosis needs a lumbar puncture. So even in individuals, as I was saying before, who have a positive cryptococcal antigen but no symptoms, there is a risk that they could actually have meningitis, but they just haven't developed symptoms yet. So one of the main messages is that everybody with a positive blood crag needs to undergo a lumbar puncture. We know that in lumbar punctures, around a third of patients have raised intracranial pressure with an opening pressure greater than 30 centimeters of water. The key real diagnostic rapid test on the CSF is, again, the cryptococcal antigen, which has a 99 to 100%, about 99.7% sensitivity. There are also direct microscopy tests. There's India Ink that has a lower sensitivity. And the gold standard is culture of Cryptococcus. But that is a little bit more technically complex because, of course, it takes time for a culture to turn positive. So really, the most important diagnostic is actually the cryptococcal antigen for diagnosing someone with a first episode of cryptococcal meningitis. You can also see on the CSF parameters that the white cell count may be elevated, predominantly lymphocytes, but it could be normal. The protein may be elevated, could be normal. And the glucose is normally normal or maybe ever so slightly low, but not normally as low as you would see in TB meningitis. Now, measuring opening pressure is, of course, very simple if you have a manometer, because you just measure the pressure. But if you don't have a manometer, there are some very clever people that have tried to look at other ways that you could try and measure the intracranial pressure. And I'll invite you to read these references here to explore how people have used either IV giving sets attached to the LP needle, or measurements of the drip rate, so how quickly the fluid is coming out of the lumbar puncture needle, to understand if there's raised intracranial pressure. Or what you could do is just see with your patient if the lumbar puncture helps to alleviate their headache. If it does, it's likely that the pressure was raised. And I think we would all be able to see from our experience, when you're doing a lumbar puncture, when the fluid is coming out very quickly, you can get that impression too. One of the things I'd like to just discuss, because I think this is a larger issue than any of us kind of really appreciate, is lumbar puncture refusal, which is very, very common, particularly in high prevalence settings. And I think there's lots of very complex reasons why individuals refuse lumbar punctures. And quite often that is based on the fact that previously they will have known someone or known of someone who would have died of cryptococcal meningitis, and probably died quite shortly after having had a lumbar puncture. So these individuals have got this relationship in their mind that lumbar punctures are associated with death, where of course what's actually happened is the cryptococcal meningitis is what's killed them. So it's really important to appreciate that standpoint and to really try and explore that with your patient and with their relatives, because we've seen within our experience with clinical trials that it is possible to try and work around these understandings and these concerns around lumbar puncture, and to encourage people to take lumbar puncture. And one of the things that Kennedy is going to talk about later is some of our work around trying to improve lumbar puncture uptake. Because again, the message that's really clear here is that everybody needs to have a lumbar puncture to diagnose cryptococcal meningitis. And the majority of people need more than one to manage the pressure, because the raised pressure around the brain is a really significant contributor to mortality. So going back then to the cryptococcal antigen screening, anyone with a positive serum CRAG should be encouraged to have a lumbar puncture. If that lumbar puncture is positive, they have cryptococcal meningitis. If it's negative, they need to be managed with something called preemptive therapy. And we'll talk about that next. However, if it's declined, then the treatment should really be based on the absence or presence of neurological symptoms, but it is likely that you will miss cases of subclinical meningitis. So the management for antigenemia is fluconazole 1200 milligrams a day for 14 days, followed by fluconazole 800 milligrams a day for 8 weeks, and then fluconazole 200 milligrams a day thereafter. So there's also some other studies going on at the moment to explore if perhaps fluconazole is not enough for these patients with positive serum CRAG, and we'll look forward to hearing the results of those. So cryptomeningitis, when an individual is diagnosed with cryptomeningitis, there's been a lot of development in recent years with new shorter courses of less toxic treatments having been realized through some new trials. And the reason for this is that we know that fluconazole monotherapy is not enough. The mortality is extremely high. And that actually the majority of patients for a long time have been getting amphotericin B deoxycholate and fluconazole. And we know that from our routine data in Botswana, that actually the mortality with this 2 weeks of amphotericin and fluconazole is about 50%. And that's partly because of the high toxicity of the amphotericin B deoxycholate, which we know causes thrombophlebitis, prolonged hospital stay, infusion reaction, anemia, renal impairment, and electrolyte dysfunction. So what's happened in recent years is a number of trials aiming at reducing the toxicity from amphotericin B deoxycholate. And the first of these large trials was the ACTA trial, which demonstrated very clearly that if you swap your fluconazole for flucytosine, you can actually give amphotericin B deoxycholate for just 1 week. And this was the best arm in the ACTA trial, 1 week of amphotericin B with flucytosine. So we learned in this trial that you can give less amphotericin B if you have flucytosine. But if you don't have flucytosine, the mortality is much higher if you're partnering with fluconazole. So 24-41. We also learned as well that actually flucytosine and fluconazole are quite a good oral combination. They're not as good as the amphotericin and flucytosine combination, but they're still good. And the message from this is really that flucytosine is a very essential antifungal for cryptococcal meningitis. But what about liposomal amphotericin? Well, this we know is less nephrotoxic. We know it gets into the brain and that it has quite a long half-life. And actually, it had been shown in other trials for other conditions that you could treat these conditions with a single high dose of liposomal amphotericin. And because we know that the liposomal amphotericin is not widely available and is rather expensive, we wanted to explore whether it would be possible to give a single high dose of liposomal amphotericin for cryptococcal meningitis. And this is what led to the AMBITION studies. So there was at first a phase 2 study which trialed a series of shorter high dose courses of liposomal amphotericin for cryptococcal meningitis in Botswana and Tanzania. And in this study, we found that a single high dose at 10 milligrams per kilogram of liposomal amphotericin was just as good or non-inferior to daily dosing with daily liposomal amphotericin B. And this is what led to the AMBITION phase 3 trial, which was published last year. So the AMBITION phase 3 trial was the largest HIV-associated cryptococcal meningitis trial ever conducted and trialed these 2 regimens here. So the interventional arm was a single high dose of liposomal amphotericin at 10 milligrams per kilogram. And this was given with 14 days of flucytosine and fluconazole. The control regimen was the previously WHO 2018 recommended first-line treatment regimen, which was the ACTA trial best performing regimen of 1 week of amphotericin B and flucytosine, followed by fluconazole. And so this was the AMBITION phase 3 trial, which was conducted, including with many members on this call, in 5 countries in Southern and Eastern Africa. And the results were published in the New England Journal of Medicine. And it was very clear that the mortality, this was a non-inferiority trial. We were looking for not necessarily a better performing regimen, but one that was also going to be safer and easier to administer. And it was quite clear here with the mortality at 10 weeks that in the liposomal amphotericin B arm, the mortality was 24.8%. And in the control arm, it was 28.7%. And that's, that's also pictured here on the left. This is a non-inferiority diagram showing that actually towards the left, the liposomal amphotericin regimen was non-inferior and in some cases was actually superior. And we also know that there were fewer toxicities in this regimen, so fewer grade 3 or 4 adverse events. And that was really, really clear when we looked at the fact that the change in hemoglobin in the AMBITION regimen was only a drop of 0.3 grams per deciliter of hemoglobin over the first week, compared to minus 1.9 in the control arm. The creatinine went up 20% in the AMBITION regimen versus 50% in the control. We saw less hypokalemia, less thrombophlebitis. We needed fewer blood transfusions. So it was deemed that this was a very, very efficacious, but also safe regimen to give. And when we looked at how well it cleared the Cryptococcus from the brain, it was also similar and no statistically significant difference to the control regimen. I'd invite you to also look at some of the sub-studies within Ambition, where we found that from a cost-effectiveness analysis, the Ambition regimen costs between $71 and $121 per life year saved in the 5 country settings where the trial took place. And also where we explored the fact that the Ambition regimen was highly acceptable and preferred by both the trial participants and also the clinicians. And I think this is something that we expected, because the regimen was designed to be much easier to give by just having the single intravenous infusion. And we were very pleased to have that confirmed with this research. And there has been quite a significant amount of momentum around cryptococcal meningitis since the release of the Ambition results. So the results were published in March 2022, and then less than 1 month later, the WHO issued rapid advice saying that they were updating their first-line regimen to the Ambition regimen. And it's already being used in routine care in numerous high-incidence countries, which is largely in thanks to an access program supported by Unitaid and CHAI, which means that the liposomal amphotericin and the flucytosine are available in countries that see large numbers of cases of cryptococcal meningitis. So these are the updated WHO guidelines. They're available online, and they confirm that the preferred induction regimen is this single high-dose liposomal amphotericin regimen. In addition, I just want to point out some of the post-induction management for cryptococcal meningitis. So everyone is treated with a consolidation phase of fluconazole for 8 weeks after they finish their induction, and then their maintenance treatment of fluconazole until their CD4 count is greater than 100, their viral load is suppressed, and for at least 12 months. With our team, we have been trying to create some educational materials to help with the implementation of the Ambition regimen in routine care. So here you can see the link for our YouTube video with our team at Malawi Liverpool Wellcome Trust, and Ebi Gumbi-Gondwe, who is our senior research nurse in Blantyre, showing individuals how to reconstitute the single high dose. And also our colleague, Dr. Melanie Alufandika-Moyo, explaining how best to dose the regimen and how to manage any of the drug-related toxicities. The monitoring schedule for the Ambition regimen is much more simple than it has been for previous regimens and is outlined here. Individuals need to receive oral potassium and magnesium supplementation for 3 days rather than the previous 7 or 14. And they just need baseline bloods, a day 3 renal function, and then a day 7 full blood count. So it's a much simpler monitoring schedule. And then just to say, and these are very useful resources to come back to, but it's really important to have a protocolized way of managing raised intracranial pressure, because individuals do die from raised intracranial pressure, and some of them will require a daily lumbar puncture. And I believe within the Ambition trial, there were several participants that had more than 70 lumbar punctures during the course of the trial. And that's because the management of the raised intracranial pressure is such a critical component of cryptococcal meningitis management. We've also developed guidance and expert opinion on how to manage antiretroviral therapy in these individuals, because we know from very well conducted randomized controlled trials that ART should not be started at the point of induction therapy, but that there needs to be a delay of between 4 and 6 weeks before individuals start ART to avoid an immune reconstitution inflammatory syndrome. And we also provide guidance on what to do about individuals who are ART experienced, who perhaps haven't been on ART for a while. So please do go and have a look at that. And then just a few notes on iris and relapse. Individuals can present with an unmasking iris. That can be the way that we find out that they have cryptococcal meningitis. And that really emphasizes the need for cryptococcal antigen screening when individuals come back to care and when they're diagnosed for the first time. But we also know that individuals can develop a paradoxical iris. So even after they have been treated for meningitis, when they later start their ART, they may develop a recurrence of symptoms. However, this is very less common when someone has had very good induction therapy, as with the Ambition and the ACTA regimens, but it still does happen. And an iris is most commonly characterized by a really inflammatory reaction, as you would imagine. So raised intracranial pressure, raised CSF protein and white cell count, and often a negative CSF culture on a background of good adherence to both fluconazole and antiretroviral therapy. We don't give steroids for induction therapy with cryptococcal meningitis. That has been definitively proven to be associated with harm and worse outcomes for induction therapy. But it may be that in cases of paradoxical iris, where you're not able to get on top of the raised intracranial pressure with lumbar punctures, that those individuals may benefit from steroids on a case-by-case basis. But steroids are absolutely not routinely recommended for cryptococcal meningitis. Relapse is different because relapse is really about a regrowth of the cryptococcus of the actual infective pathogen. And this is often in the context of individuals who have struggled to adhere to their fluconazole. And the differentiation here is that the CSF culture will be positive because there's active pathogen in the CNS. So that is a whistle-stop tour of the entirety of cryptococcal meningitis. You have my contact details there and my Twitter handle, and you'll also have these slides available. And I'll welcome any questions in the chat and later at the panel discussion. Thank you very much.
Okay, thank you, David Lawrence. And as David said, there are a couple of questions in the chat. If you could just go ahead and start responding to some of those, that would be very helpful. I'd like to move on now to the next presenter, who will be Dr. Tsepo Lim. I hope I have correctly pronounced that. And just to let you know that she's a public health resident at the University of Botswana and holds an MBBS from Monash University in Australia and a diploma in tropical medicine and a master's level training in epidemiology, both from the London School of Hygiene and Tropical Medicine. She has worked in cryptococcal meningitis research that evaluated newer treatment regimens for treatment of HIV-associated cryptococcal meningitis over the last 6 years and has published work on advanced HIV disease and cryptococcal meningitis. Tsepo, you're welcome, and we look forward to your talk. Please go ahead.
Thank you very much, Prof. Meyer, and good morning and good afternoon, everyone. So I think mine would be easier because I think David has done a lot of my work. So we'll go through a few cases, and then just because we can't have a proper discussion, I have some poll questions that I would ask you to attempt as we go through the cases, just so that we really reiterate what David has just presented. Next slide, please. So our first case is a 41-year-old male who presented to hospital complaining of a headache that has been present for 2 weeks, and he rated the headache as 9 out of 10. He also has unintentional weight loss and anorexia. He's also never tested for HIV, so he does not know his status, but his past medical history is unremarkable. He has never been treated for TB. On examination, his vitals are as follows. His temperature was 35.8. His pulse was 52 beats per minute, respiratory rate of 18. He was saturating at 99% on room air with a normal BP, normal mental status, and had a weight of 54 kg. He didn't have any signs of meningism or any focal neurological deficit. And then the rest of the examination was also unremarkable. And we performed an HIV test on this gentleman, and then it came back positive. Next slide, please, which is a poll question. So the question is, list the investigations that you would perform on this patient. So you need to select all that apply. The first alternative is CD4. Next one is serum CRAG, urine TB LAM, FBC, LP for MCS, India Inc. CRAG, as well as GeneXpert, and then FASH, as well as electrolytes, urea, and creatinine. So may you kindly attempt to see how we would investigate this patient to see what's going on. So we just have 30 seconds for the poll. Okay, thank you. I think a few of you have answered, and I can see that majority of you are choosing all of these investigations, and so we would do all of them. We will do a CD4 just to see whether this patient has advanced HIV disease or not, because we have also been, David has just explained that, with advanced HIV disease, there's also a comprehensive package of care that we need to be offering these patients in terms of cryptococcal antigen screening, cotrimoxazole prophylaxis, as well as screening for TB with urine LAM. So we would do a CD4 count, and if this patient, we think maybe has crypto, we know that the CD4 is going to be quite low. We would also do a serum CRAG, and in some setting where CD4 count is routinely done, we know that they do reflex CRAG testing in the lab. So when they do the CD4 count, they would also do the CRAG as it's recommended by the WHO to do a CRAG on anyone who has a CD4 count less than 100. There's also a recommendation to do that on people with CD4 counts less than 200. That is if resources allow in some settings. We would also do a urine TB LAM just to see whether there's any TB in this patient, because he's also reported that he has unintentional weight loss. We would do our routine bloods and the full blood count, as well as the renal function test. And then we would also do an LP, since the patient is also presenting with signs of possible meningitis. Next slide, please, which is also another poll question. So we did perform a lumbar puncture on this patient, and the opening pressure was 32 with a white cell count of 5, glucose of 2, protein of 1.7 grams per liter. The India Inc. was positive, as well as the CRAG. We obviously would not have a culture in this patient on day one that we are doing these investigations, but obviously 48 hours or so later, we would have a culture, and it has come back positive for cryptococcal neoformans. So what is your diagnosis? Alternatives are acute bacterial meningitis, TB meningitis, cryptococcal meningitis, herpes encephalitis, cerebral toxo, and malaria. So I'll just give a few seconds for people to complete the poll. Okay, thank you. I think that's fine. So majority of you thought the answer is cryptococcal meningitis. 2 people thought it's TBM. 1 person thought it's toxo. I mean, I think because we have the results of the lumbar puncture, and they clearly show us that the India Inc. is positive and the CRAG is also positive, and a few days later with a positive culture, this is more pointing really towards cryptococcal meningitis. Next slide, please. So now that we know that the patient has crypto, the question is, what treatment would you commence? And you are assuming all drugs are available to you that David discussed in his previous talk. So the first alternative is a single dose of liposomal amphotericin B at 10 milligram per kg per day, or just for 1 day, plus flucytosine at 100 milligrams per kg in 4 divided doses, and fluconazole 1.2 grams for 14 days. Second option is amphotericin B 1 milligram per kg per day with fluconazole 1.2 grams for 14 days. Option C is Ampho B 1 milligram per kg per day with flucytosine for 7 days, then followed by fluconazole 1.2 grams for 7 days. Fourth option is liposomal amphotericin B 3 milligrams per kg per day plus fluconazole 1.2 grams for 14 days. And then the last option is the oral option, which is flucytosine and fluconazole for 14 days. I would allow a few seconds to have the answers in. Great, thank you. So 50% of the class went for option A, which is the single dose of liposomal amphotericin B plus flucytosine and fluconazole for 14 days. And then the next popular one was the Ampho B 1 milligram per kg per day with the flucytosine for 7 days, then fluconazole for the rest of the days. And then 15% went with the 3 milligrams of liposomal and fluconazole for 14 days. So the correct answer, as per the current WHO recommendations, is the single dose, is option A, which is the single dose of liposomal amphotericin B at 10 milligram per kg, plus the flucytosine at 100 milligram per kg per day in 4 divided doses, plus the fluconazole for 14 days. So that is the current first-line recommendation as per the WHO. And I think the next question would probably ask about the second line, so I would not go on to that. So that is what was shared from the ambition study results by David earlier. Next question, please. So in the initial question, we assumed all the drugs were available. So now we don't have the liposomal amphotericin B. So what would be your option or your preferred option if you don't have the liposomal? So first option includes liposomal amphotericin B and flucytosine, the single dose. The second option is amphotericin B 1 milligram per kg per day and fluconazole for 14 days. Third option is amphotericin B 1 milligram per kg with flucytosine for 7 days, followed by the 7 days of fluconazole. The fourth option is liposomal amphotericin at 3 milligrams per kg with the fluconazole for 14 days. And then the last option is the oral option of flucytosine and fluconazole for 14 days. So what treatment would you give this patient if you did not have the liposomal amphotericin B? So I guess I don't expect anyone to choose option A or option D because you do not have that drug. Okay. So these are the results here. We have 6 people who chose option A and 5 people who chose option D. And we should not be choosing those options because we do not have the drug. Then the patient is not going to get any medicines. So for this one, then the second option would be the WHO recommended second line, which is the shorter regimen with the amphotericin B deoxycholate. So this one, you would then give the patient the Ampho B deoxycholate at 1 milligram per kg per day with the flucytosine at 10 milligram per kg per day in 4 divided doses for the first 7 days. And then for the rest of the 7 days of the induction phase, we give fluconazole 1,200 milligrams. And then lastly, next question, please. So lastly, now we do not have any of the amphotericin B formulations. So what would be your preferred regimen? I think this one is easy. So we do not have any of the IV formulations of amphotericin. So what would you give? The options are still the same. The first one is the single dose liposomal amphotericin B and the fluconazole and flucytosine for 14 days. Second option is ampho at 1 milligram per kg plus fluconazole. Third option is ampho and flucytosine for 7 days, followed by fluconazole for the rest of the 7 days. Fourth option is liposomal at 3 milligram per kg per day, and the 14 days of fluconazole. And lastly, it's the flucytosine and the fluconazole for 14 days. And here are the results. We still have people given the IV formulations, although we do not have them. But the correct answer is the oral formulation, which is the flucytosine and the fluconazole. So this was shown in the ACTA trial that it showed that mortality was reduced in the patients who were taking flucytosine and fluconazole when you compared that to the patients who were taking the standard of care of treatment at the time, which was the 14 days of ampho and fluconazole. So they showed mortality of about 35%, which was less than the standard of treatment. Next slide, please. So just to also just to touch on the principles of management again, as David has already said. So what's important when we give our patients the medications, with the new formulation, we have to give it in a liter of 5% dextrose. If we use any other fluid, the medicine would crystallize and you actually won't be able to infuse it through into the patient's veins. So it's always important that we mix it with the D5. And it's also important that we prehydrate our patients. We give them 1 liter of normal saline with 20 millimoles of KCl, because we know that the amphotericin formulations are more likely to cause hypokalemia. So we need to make sure that we preempt this and we give IV KCl, and we also give the slow potassium tablets. So we give 2 tablets of about 600 to 1.2 milligrams BD. So for the liposomal, you're going to give it for 3 days. And if you have slow magnesium available to you, you also give the 2 tablets of the 535 milligrams to the patient for the 3 days. And then you have to also make sure that you post-hydrate your patients just to make sure that you wash out all the toxins from the medicines. And then we also need to remember also to do monitoring with FBC and renal function to monitor for toxicities. So the hypokalemias and hypomagnesemias of our patients. We are less likely to see this in patients who are receiving the liposomal amphotericin B compared to the ampho-B oxycolate, as it was illustrated by David earlier. Next slide, please. So now we'll go on to another case, which is a 38-year-old female who has been diagnosed with crypto. And he has been HIV positive since 2015. He's on TLD, so tenofovir, lamivudine, and dolutegravir. So he had some renal impairment at baseline with a creatinine of 190 and urea of 12.7 on day 1. So he had admitted to passing reduced volume of urine for a week prior to coming to hospital, but he denied any vomiting or diarrhea. So on day 5 of treatment with ampho, B-deoxycholate, and flucytosine, so he's taken the second recommended regimen, which is the amphotericin B-deoxycholate at 1 milligram per kg and the flucytosine for 7 days. Then the rest of the days he will take fluconazole. So he's on day 5 of treatment. His CD4 count is 5 and he's not virally suppressed. His past medical history, so he has hypertension since 2 years ago, and he is on hydrochlorothiazide 20 milligram OD. So his creatinine since day 1 has been increasing. So on day 2, it was 200. On day 3, it was 220. And now on day 4 is 274. On examination, he is alert. He is GCS is 15/15. His BP is 157/109. Pulse rate is 93 beats per minute. Respiratory rate is 18. His temperature is 35.3. But the rest of the exam is unremarkable. Next slide, please. So this is another poll question. So please give plausible explanation of this man's acute kidney injury. So you may tick all that apply. The first answer is amphotericin B nephrotoxicity. B is HIV-associated nephropathy. C is hypertensive nephropathy. D is TDF toxicity. E is herbal medications. And F is other drugs such as NSAIDs. And you can take all that apply. I will end it there. So these are the results. So all these are possible differentials for this patient. So really we would have to even take thorough history, maybe to see whether he's taken any traditional medicines before coming to hospital. We would also need to review the patient's drug chart to see whether he's on any other nephrotoxic drugs except the amphotericin B, which we know also it's a culprit for causing renal impairment. HIV-associated nephropathy is also common. We see that he's had HIV since 2015, so it's possible. Hypertensive nephropathy also possible given the past medical history of hypertension in this patient. Next slide, please. So the first poll question, if you could please project it. So the following are side effects of amphotericin B deoxycholate toxicity except alternative one is nephrotoxicity, B is anemia, C is hypokalemia, D is hypomagnesemia, and E is thrombophlebitis. So which one is not a side effect of amphotericin B? Okay, I will end it there. So majority have said it's hypermagnesemia, and that's the correct answer. So nephrotoxicity, we said it's common. Anemia is also quite common in patients who are taking ampho-B. Studies have shown that the average drop or the mean drop in hemoglobin from day 0 to day 7 or 14 in patients who are taking ampho-B, it's about 2. So we do expect that patients who are on ampho would have a drop in their on their HB at some point during treatment. Hypokalemia, I've also just said that it's also common in patients taking ampho. This is why when we prehydrate them, we give them the KCl, and we also give the oral supplementation of potassium. Thrombophlebitis is also common and sometimes even require antibiotics. So the next poll question, please. So the following are side effects of flucytosine except option 1 is anemia, option 2 is aplastic anemia, option C is pancytopenia. So if you could project the question, please. Option D is hypokalemia, and the last option is nephrotoxicity. Okay. Okay, I think I have stopped the poll by mistake, but I think we all would have got the answer. So the one that's not, so with flucytosine, I think it's okay, we can just proceed. With flucytosine, the common side effects are the hematological toxicities. So the first three you would see in patients who are taking flucytosine. Nephrotoxicity is also possible in patients taking flucytosine. So the answer there is hypokalemia. Next slide, please. So just continuing on the same man. So we are treating him for cryptococcal meningitis, and we know that he's been on ERT since 2015 and he's on TLD. Since he's been living with HIV since 2015 and he has been on TLD since 2019. He is virally unsuppressed. And so we really, if someone is on ART, really, we do not expect them to be coming in or presenting in with crypto. So we really need to understand what is happening with this patient. Why is he on ART? He's not suppressed and he's coming in with opportunistic infections. So what's important is now, what are we going to do with his ART now that we are treating him for crypto? Because we really need to understand his adherence, whether he's been taking these medicines or not, because we have had issues of patients who are on ART and then they default treatment. And then once they find that they start feeling well, they have their medicines somewhere in the cupboard, then they reinitiate themselves on ART. And these patients would present to them with CM, with unmasking iris. So we really, really need to ask detailed adherence history, because that would help us to see what we are going to do with the patient's ART during this admission. So if the patient says to us he's been taking his ART religiously, never miss a dose, then it's important that we consider drug resistance in these patients. But because we really need to make sure that, I think sometimes you have to use your intuition as to whether you should believe the patient or not, because sometimes they may say they're taking the ART while they actually were not taking the ART. So if now we also, I think another important thing is, if this patient tells you that, no, I have not been taking ART, I was given the ART, but I have just been keeping it at home, it's just taking it on paper. So these are the patients that you can consider stopping the ART during the admission while you are actually giving them the antifungal therapy, and then you restart the ART later. But also, when you consider stopping the ART, you should also think of other diagnoses that this patient has, because you need to think about whether this patient also has coexisting or comorbidities like hepatitis B, because then if they do have the hepatitis B, you need the tenofovir for you to be able to treat them during the time that they were in hospital. And we also need to be able to offer ongoing adherence counseling and support to the patient, so that even when they leave the hospital after treatment, they can go home and then, do better in terms of their adherence if they were not really adhering very well. Next slide, please. So in this patient, so the ART was stopped. So then the question is, when would you restart his ART after you have stopped it? The first option is 1 to 2 weeks after starting the antifungals. Second option, once the patient has tolerated the antifungals. C is 4 to 6 weeks after starting the antifungals. And D is once they start fluconazole consolidation therapy. Right, I will end it there, and I think majority of us are correct. So 73% of the people has said 4 to 6 weeks after starting antifungal therapy. So that's the correct answer. So I think maybe some of us would be familiar with the CODE trial, which was conducted by Prof. Meyer and his colleagues. where they looked at the optimal timing for ART for patients who have been treated for cryptococcal meningitis. And they illustrated that mortality was quite high if you started ART at the same time that the patient was receiving the antifungal therapy. But when they deferred ART to 4 to 6 weeks, they showed better outcomes in those patients, and hence that recommendation by the WHO that ART should be deferred to 4 to 6 weeks after starting the induction phase of therapy. Next slide, please. So now we'll go on to the last case. So this is a 24-year-old female who has been living with HIV and has been on treatment since 2012. They came to hospital with recurrence of headache and blurred vision and was diagnosed with crypto 6 weeks ago. So the patient was reinitiated on ART, was reinitiated on TDF3, TC, and DTG 2 days ago. So they had finished induction and now they were started on ART 2 days ago. And she has not been taking her fluconazole for the last 14 days. So today the patient complains of severe headache and blurred vision for a day. The headache is generalized and of gradual onset, non-radiating, associated with blurred vision. Has vomited once, no photophobia, neck stiffness, or fever. And on examination, she's prostrated and weak vitals, temperature 35.7, pulse 119, respiratory rate of 20, BP normal, saturating okay on room air. Other examination, no meningism, but has reduced power of 3/5 on all limbs, but normal tone and reflexes. Next slide, please. So a lumbar puncture was done on this patient. Her CSF opening pressure was 34 elevated. White cell count was 2, glucose 2.6, protein of 0.46. India ink and Craig were positive, and they grew Cryptococcus neoformans with a fungal culture of 3,000. Next slide, please. So then the question is, what is your diagnosis? The options are A, persistent wrist ICP, B, acute bacterial meningitis, C, TBM, D, relapse of crypto, E, iris, F, space occupying lesion, G, malaria. Okay, I will stop it there. So 66% of you think it's relapse. A few people said 18% said it's CM iris. So majority of us are correct. So it's CM iris, as you saw that the patient has grown something on culture. I think the next, I'm probably giving you the answers to the next question. So next slide, please. So now, what are the, so next poll question, please. So the following are common in CM iris than relapse except. So what's more common in iris compared to relapse? So raised ICP, high CSF protein or white cell count, negative culture, good adherence to antifungals and ART, and positive culture. Okay, I will end it there. So 31% have said negative culture. About 26% then said good adherence, and then same 26% said positive culture. So the correct answer, so with iris, as compared to the scenario that we saw earlier. So the patients would have negative culture. So once they come in and, with the same, probably similar symptoms, and you send a sample for culture, the culture will come back negative. And mind you, these patients, when they come in, their India ink may still be positive, because India ink doesn't distinguish between dead fungus and live fungus, and also with the CRAG, the CSF CRAG, you may find that is still positive in this patient. So it's really important that for these patients, we wait to see what the culture is doing. I know that it means you have to wait for 48 hours before you can make that decision. But that's the key to determine whether really you need to re-induct these patients on antifungal therapy or not. So then I think the next one, it's on what would happen with relapse. So that's the opposite of what we said earlier. So with relapse, then we would find that the patient would have a positive culture. So I think that's okay. I believe majority of you would have gotten that from the explanation that I just gave. So next slide, please. Okay, so in terms of managing a relapse, because we now know that the patient has grown something, we just restart the induction therapy as we would with a patient who's just coming in for the first time. So we would give this patient what is the recommended first line. Now, if we all have the medicines available to us, we will give them the single dose of the liposomal amphotericin and the oral flucytosine and fluconazole for the 14 days. And just to remind you to always give the potassium. It's important, I guess, with your baseline renal function and electrolytes also to see what the potassium is doing, so that the patient's potassium is not 6 and we are giving that patient supplementary potassium. So it's always important that we see what the baseline potassium is doing. And also it's important that we also do that continuous monitoring for toxicities for patients, although not as rigorous as when we are given the amphobetis oxycolate, but we should make sure that we do the baseline, and then maybe on day 4, we also check what the renal function is also doing on day 4. Next slide, please. And then in terms of managing CM-Iris, so it's always important, again, when the patient presents, we exclude other CNS opportunistic infections like toxo and TBM. So we should not just assume that it's CM-Iris before we have the results of everything, but we should also look for other CNS opportunistic infections. If the patient's has raised ICP, we should rigorously also manage that, do daily LPs if we need to, until we have 2 consecutive normal opening pressures for those patients. Make sure we reassure the patient that, this can happen. It's not a relapse, since they would be telling you that they've actually been taking their medicines and they don't know why this has to happen to them. So we really also need to assure our patients, and we should not stop ART in these patients. And again, just to emphasize this, David did say about the steroids in crypto, and also with Iris, if the patient is really, really not that sick, then you can consider not giving them, or we should not be giving them the steroids, but only if they have intractable symptoms and raised ICP. That's when, and they're not getting better with all the treatment that you are giving them, that's when you can consider giving them the steroids. Next slide, please. Must be my last slide. Okay, thank you very much for your attention.
Okay, thank you very much, Dr. Tsepo. I think that was a really comprehensive case review, and I'm sure that many people have used this opportunity to learn. We're going to move on to our last presenter, and I know we don't have much time, so we will definitely try and be as quick as we can. But Kennedy Mupeli is a 2017 AVAC Advocacy Fellow who implemented pre-exposure prophylaxis projects on education, advocacy, and networking with civil society organizations to advocate for acceleration of PrEP delivery. He's also a 2019 ISQ Advocacy Fellow and the co-founder of U=U Africa Forum. Kennedy, please take it away. And I believe we have 16 minutes to have your talk, and maybe take 2-3 questions, or have 2-3 questions discussed by the panel. Thank you. Please go ahead.
Well, thank you so much, David. I think we'll just dive into the next slide. Yes, so I'll just quickly run through the history of civil society organization in advocacy. Most of you remember those that lived longer than who lived before 1983. Remember the 1983 Denver Principles. This is a conference that took place in Denver, and policymakers were discussing issues around the HIV in the exclusion of people that were living with the disease at that time. And comrades, went to the venue site and demanded to be part of the discussion. And over time, we saw the greater involvement of people living with HIV that culminated into, the JIPA principle in 1994, and MIPA, which means meaningful involvement of people living with HIV. As civil society organization, we've been so instrumental in advocating for treatment. We've also been instrumental in advocating for prevention, and we've been implementing science-based, advocacy over all these years. So what has happened? This is a timeline from the Denver Principles. We have the greater involvement of people living with HIV in 1994. And so much excitement around 2007 when the GPP guidelines were specifically developed, to guide clinical trials and research. And also in 2019, the NIHR community engagement document was released. This focused on low and middle income countries. Next slide, please. Next slide. Yes, so we know, as much as we are aware that if you see this map, we are doing quite well with crack testing by country, especially in high burden countries. But some, limited access, even crack testing available. Where crack testing available, there may be shortages, of preemptive fluconazole. So this is another, window of opportunity for civil society organizations who are in this core to try to push your respective Ministry of Health to really, upscale the availability of crack testing, and also not only upscaling it through the memos, but also, embedding it in respective treatment guidelines. Next slide, please. So the liposoma amphotericin, as David said in his presentation, is being provided by United and CHAI in their AHD, Advanced HIV Disease Initiative, but it's hoped that the access will increase in the near future, and because we can see that it's not enough, and this is the time that civil society organizations that are present here to be able to tap into this opportunity to be able to scale this up. Next slide, please. So flucytosine is registered in very, very few countries. And it's special, it requires specialized importation licenses are being used on ad hoc basis to allow importation of the absence of this drug, and its registration also is quite some vigorous process. And this is another opportunity for a civil society organization present here to be able to tap into this and be able to advocate for full access to flucytosine. Next slide, please. So as civil society organizations, we've been so supportive to ensure that we have better treatment outcomes. We have done this through peer education, and also we are involved in clinical trials, mainly as community advisory board members, and also we have led the kind of peer educators with lived experiences to educate the community about cryptococcal meningitis. We have also we continue to robustly scale up integration of cryptococcal meningitis basic science into existing ACE programs. We need to see crypto, forming, the part of the overall, the wider HIV prevention and treatment messaging, and also including this messaging in patient-facing materials and treatment literacy materials. We have also been able to continue designing and carrying programs that aim to reduce refusal rate of lumbar punctures. You must also be aware that there are a lot of myths and misconceptions about lumbar puncture. And we are also doing this to be able to counter these, to counter the myths and misconceptions around lumbar puncture. So we also want to start, or we are already advocating for ambition regimen to be accessible, and routine Craig screening and preemptive treatment for new regimens to be investigated in new treatment guidelines, into treatment research, so that we can be able to have better treatments. So HIV fungal-related research, including better advanced HIV disease packages, is what the civil society organizations that are present here should also be focusing on. Next slide, please. So we are developing patient-facing materials in form of posters and flyers. We are developing videos. We hope to, with the aim of trying to address the rate of lumbar puncture refusal among patients who need lumbar puncture and community at large. So these are pictures of Tsepo here, who was just the previous speaker, doing a short video with the video crew here. And we hope in the next 1 or 2 months, these materials will be out and we'll be able to share them. Next slide, please. Next slide. Yeah, so we are at the center of everything, from community education, we play a role in enrollment and retention. We also advocate for acceleration of product approval and finding priorities for those products that need, urgent approval. And as communities, we play that major role. And also, we are part of the research process. We play a critical role in the research process in defining and designing relevant research questions. We also participate in all this process in interpreting the study results and disseminating them. Next slide, please. So yes, so we know, and several studies have actually attested to this, that meaningful engagement, civil society meaningful engagement is mutual benefit, plays a mutual benefit both for patients and the researchers. And civil society organization advocacy efforts should be credited with funding priorities and policies that enable ongoing research. And also, lastly, we demand that in countries that have not yet moved in, we need treatment guidelines, because without the presence of treatment guidelines, printed treatment guidelines, most physicians find it difficult to follow, just like something that's just put on the notice board in the hospital. We need printed guidelines that doctors can refer to as they treat us. So we need the robust implementation of the ambition CM regimen in countries that have not done that yet. We also need continued research for shorter course treatment regimens. There's still room for further research. We need fungal immunotherapeutics or vaccines. There's another area that I think we should invest the next phase of fungal trials. Then we also need, this has happened in HIV and anti-pregnancy, technologies. We call it multi-purpose prevention technologies. Why can't we have the same preemptive treatment in single dose for C, cryptococcal meningitis, and TB preventive treatments? Thank you so much. We just end here for the sake of time. Thank you so much.
Okay, thank you very much, Kennedy. I think this has really been an excellent combination of talks, from the research aspect to the clinical aspect, and now to the civil society aspect. I'm just going to ask one or two of the panelists to just respond. I think one, I will start with Ajay. Given the entry point for early diagnosis of cryptococcal disease is CD4 screening, and the potential issues that we know have been coming up with access and availability. What do you think needs to be done to ensure that CRAG screening remains a priority in settings of high disease prevalence? And just to note that Ajay Rangaraj is with WHO headquarters, and so your insights would certainly be helpful to listen to. Thank you. Please go ahead.
Yep. Thanks very much, David. I think the most important thing that I'd like to emphasize here is that sort of at WHO, we're working quite extensively with our key donors, Global Fund and PEPFAR, to really make sure that we're all very well aligned in terms of ensuring that CD4 is made available. So I think we know that in many settings, individual access to CD4 has been challenging, but we're looking to see if we can ensure that point of care CD4 tests are made available, such as the Visitect CD4 or the PIMA. And I just want to emphasize that it's extremely important to be identifying advanced disease as early as possible, for the main reason that if you were to do clinical staging, it usually means that you're also detecting some kind of co-infection at the same time, which means that it acts as a sort of disabler of the AHD package, because you want to really be offering preventive treatment rather than offering full treatment for a disease. So I think I would like to emphasize that we are encouraging adoption of the package in full, and which includes CD4, CRAG, TPP, screening, systematic screening for tuberculosis, so on and so forth. Currently, the Global Fund as well as PEPFAR fully support the WHO recommendations. So we are hopeful that going forward in this next 1 year, we will see an increase in scale up and availability for advanced disease. Thanks.
Okay, thank you, Ajay. And I think this might be just the last question. David Lawrence, mortality, even in excellent clinical trial conditions, remains suboptimal as far as cryptococcal meningitis is concerned, that range of 20 to 25% that you highlighted. I guess my question for you is, what else do you think needs to be done practically to bring this mortality to less than 10%?
Mm-hmm. Yeah, it's a very good question. I think I would also invite you to answer that one as well, David Mayer. But I think one of the real issues is around kind of patient engagement with HIV care. Everything that happens upstream before an individual develops cryptococcal meningitis, and particularly when their symptoms do develop, if they haven't been able to access a CRAG screening program, around their awareness of cryptococcal meningitis, so a headache and untreated HIV being a deadly combination, and trying to create pathways where individuals can present to care as early as possible for diagnosis, because we know that the mortality when individuals present with a reduced GCS or confusion at baseline is almost twice as high. And really, there are some individuals that by the time they come to hospital, they are so profoundly unwell that it doesn't matter how good your treatment is, how good your induction treatment is, that it is highly unlikely that that person is going to survive. So I think there's an incredible amount of work to do upstream before individuals come to hospital or develop cryptococcal meningitis, which is why it's great to work with Kennedy on some of our implementation work. I think in terms of treatments for cryptococcal meningitis, I think in terms of the pathogen, we've got very, very good effective treatments now. We have very good fungal clearance. We have very good safety profiles. So it might be worth going back to consider some kind of host-directed therapies, considering more the host-related factors now to see if we can try and really chip away at that mortality. But I wonder, David May, if you have any insights on that as well.
So, just to wrap this up, you've obviously taken a lot of words out of my mouth, but I think, going upstream, CRAG screening to identify people fairly early, access to drugs that, we need to have, providing, better community engagement and knowledge. And I think we have this idea of setting up crypto survivor groups that should help to promote that advocacy. But I think another important aspect is obviously doing exactly what we've been doing this morning or afternoon as part of this webinar, reaching out to healthcare providers to make sure that they have the knowledge that they need, when they see these patients come to them. Thank you very much, everyone. There is a link for the survey that's been posted in the chat, and I hope those of you specifically who would like to receive a certificate of attendance for the session, please complete the survey at that link. But I'm really, really grateful for ECHO, for and the University of New Mexico for organizing this, and to the excellent speakers, Kennedy, David, and Sepo, for your excellent talks that you gave. Our next session that will be organized by Project ECHO will be entitled CD4 and Monitoring People with AHD and ART, the importance of viral load. And the question there will be, what have we learned? That will be happening on the 13th of September, 2023, and please register for that. I almost feel like I'm somebody who's saying one of those movie trucks coming to a cinema near you, but this will be coming to the next webinar organized by Project ECHO. So please register for that and attend, and have an excellent day, evening, wherever you are. Thank you.
Thanks very much, everyone.